Right, so now we're going to talk about how hip replacement is carried out. And quite clearly this is a process, and I'm not going to jump straight into the technical details of the operation, because clearly there's a few things we've got to sort out actually before that happens. The first thing is assessment for fitness for surgery, and this often is referred to a preoperative assessment, where various tests, blood tests, chest x-ray, ECG if necessary, to make sure that you're fit for the operation. And this is often done in advance of the surgery by a week or two. Coming in for the operation, again, practices have changed from coming in the night before to the day of the operation in otherwise fit patients. And most patients can accept this quite readily, and it's quite attractive as opposed to staying in hospital the night before. Once in hospital, again, there's an assessment by the doctors and the nurses, and various checks are carried out to make sure, quite for safety reasons, that we're operating on the right patient for the right procedure at the right time. And in a busy hospital, these safety checks are clearly very important. Should be seen by your surgeon on the morning of surgery to go through the procedure with you and to sign a consent form, just so that you understand the issues involved in the operation. Obviously, after preparation for the operation, eventually going down to the operating suite, again being checked in through the department and then into the anaesthetic room, where an anaesthetic is carried out. Now, as a surgeon, I'm not going to go into all the ins and outs of anaesthesia, but patients do ask this, and a lot of our surgery nowadays is carried out under spinal anaesthesia, which means it's very similar to an epidural, but except the needle goes into a slightly different layer of the spine, and this makes the legs go numb during the operation and provides very good pain relief after the operation. Now, patients again often say to me, but I don't want to know anything about the operation. Can't I be put to sleep? And I think it's a misconception to assume that just because you're having a spinal anaesthetic you have to stay awake, and the anaesthetist will discuss with you, or should discuss with you, your requirements, and they can sedate you, so you're effectively asleep if that's what you want to be. Equally, I have patients who say, I don't want to go to sleep, I'm worried about not waking up, and that's straightforward again. The anaesthetist can normally keep you fully conscious during the operation, and if necessary, you can speak to your surgeon, should you so wish, during the operation. It's a really uncanny event, but it can be done. Or else you can be somewhere between the two in this twilight zone of drifting in and out. And of course the anaesthetist will manage that interface for you. So maybe an anaesthetist should give that description, and that's just a rough synopsis of it, but the anaesthesia really is quite a very complex and important part of the procedure. And there are other issues as well, such as local blocks that can be applied, and local anaesthetic infiltrations. So moving on into theatre, actually before theatre is just draping and cleaning. In our institutions we normally double drape, which means we clean the skin twice with antiseptic and obviously drape the affected part up. Surgery can be done with you lying on your back or on your side, and surgeons have different views on the approach to the hip. If the surgeon's going in through a posterior approach, you'll be positioned on your side. If the surgeon is doing it through a direct lateral approach, which is another common approach, then you'll be put on your back. And there's a lot of care actually spent on positioning on the table with padding, protecting pressure areas, protecting you, protecting your skin, protecting your thermoregulation as well, because this is all very important for your well-being. And obviously the anaesthetist will have connected to various machines and drips and fluid assessment, etc. Having draped your hip up, the surgical team is already scrubbed and makes an incision in your leg. And the typical size of incision is about a span length of between your thumb and your index finger. Maybe I should mention at this point the trends of minimally invasive surgery, which can be done through incisions of 10 centimetres or less. And this has been tried over the last 5 years or so with great amount of publicity. And it's still carried out in some cases, but we've found perhaps using very small incisions, this isn't always ideal for getting good access and visibility. So clearly there's a bit of a balance between not making an incision that's too big, which may cause soft tissue injury or effects, versus making it too small, where the surgeon may cause more stretching. And I think most surgeons have gone to using an incision about a span length, positioned over the buttock area if it's a posterior approach. Having made an incision through the buttock area and through the skin, the fascial layers are dissected out, very much splitting tissues in the line of muscle fibres rather than dissecting across the muscle. Using a posterior approach, which is an approach I use commonly, I always check the sciatic nerve, which is the major nerve supplying the innervation to the lower part of the leg. Very important structure, and I'd just like to know where that is to make sure it's well out of the way of the dissection. Cutting through the deeper structures, the external rotators and hip capsule, eventually dislocating the hip. And the hip is a large joint, and there's quite a lot of angular movement and rotations on the leg to move it out of joint. Having dislocated the hip, the surgeon positions various retractors and other instruments to get good access, and obviously getting control of blood loss, so-called hemostasis. The femoral head, if it's a total hip replacement, is removed and resected at a certain level. And I should have perhaps said earlier that a lot of this surgery is planned on the computer now, on the PACS machine, the digital x-rays. So it's very likely your surgeon would have actually had various overlays of implants and have a variety of selection of implants and sizes in his head or her head as to what they're going to use, to have an idea of sizing and position, and also strategies to ensure as far as possible that your leg will be at the right length with the right stability at the end of the procedure. Having resected the femoral head, this makes access to the acetabulum easier. The acetabulum is exposed again using retractors, and then capsule and labrum is removed. The acetabulum is exposed, and the acetabulum is then reamed, which is a circumferential cutter to cut just through the subchondral bone into the cancellous bone structure, so an implant could be fitted.